This is the third part of the series of video presentation on basic principles of ECG analysis. I am Dr. N.S. Mani, Professor of Pediatrics from India. And in this video session, I am going to tell you how to read the ECG systematically. Step 1 is to locate the P wave. The most important and first step in rhythm interpretation is the identification of P wave and an analysis of their morphology. There are several questions that should be addressed. Are P waves visible? Each lead needs to be examined for P wave, as they may not be obvious in some leads. On occasion, P wave may be located on or at the end of a T wave and not very obvious. They will therefore cause the T wave upslope or downstroke to no longer be smooth. It is also important to look for P wave during any pause in the rhythm. Absence of P wave may occur secondary to atrial fibrillation. Alternatively, P wave may be present but not visible if they are simultaneous with and therefore be buried within the QRS complex, as in junctional rhythm or AV nodal reentrant tachycardia. These terms I have been dealing with in the last two sessions when we were discussing about the various algorithms. Of course, the models and typical ECG recordings will be shown in subsequent videos. In addition, this P wave may be located within the ST segment, as with an AV reentrant tachycardia or ventricular tachycardia. What is the rate of the P wave? That's what we have to look for. Or what is the P interval? If the rate is less than 60, then a bradycardia is present in an adult. If the atrial or P wave rate is over 100, then a tachycardia is present. These two values are mainly meant for adults. As per the age, it may be a little different in children. In general, sinus tachycardia occurs at a rate of 100 to 180. Atrial tachycardia, AV nodal reentrant tachycardia or AV node reentrant tachycardia occur at a rate of 140 to 220. Atrial rate 260 to 320 are seen with atrial flutter. So that is actually the basis behind this classification on the basis of number in the previous algorithm, which I was telling in one of the previous videos. What is the morphology and axis of the P wave? The normal sinus P wave is generally upright in lead 1 to AVF and V4 to V6. I will repeat, normal sinus P wave is generally upright in lead 1 to AVF and V4, V5 and V6. P wave is negative in lead AVR. P wave is may be negative in lead AVR. It may be negative or biphasic in lead 3 and V1. It may be negative or biphasic in lead 3 and V1. A negative P wave in the inferior lead or lead 1 suggests an ectopic rhythm, that is low atrial or left atrial respectively. A negative P in inferior lead means low atrial, or negative lead in 1 means left atrial ectopic rhythm. So that is the step 1. Now we will go to the step 2. Establish the relationship between the P wave and the QRS complex. The next step is to determine the relationship between P wave and the QRS complex, addressing the following questions. Are the P waves associated with the QRS complex in a 1:1 fashion? If not, are there more or less P wave than the QRS complex? And what are the atrial and ventricular rate? If there are more P waves than QRS complex, then some form of AV block is present. If there are more QRS complex than P wave, then the rhythm is an accelerated ventricular or junctional rhythm. So that helps us to know where the main signal originating from, whether from the atrium or below. Do the P wave precede each QRS complex, as is the case with most normal rhythm? What is a PR interval, and is this interval fixed? Do P waves occur after each QRS complex, that is retrograde P wave, as occurs in ventricular rhythm with the retrograde ventriculoatrial contraction, or in AV nodal reentrant or AV reentrant arrhythmias? The RP interval should be noted, and it should be established if it is fixed or variable. Often, establishing the relationship between the P wave and the QRS complex is the most important diagnostic step in rhythm interpretation. So that is the step 2. Now we will go to the step 3, that is analyze the QRS morphology. The QRS complex are of normal duration, that is less than 0.12 second, and morphology, normal duration and morphology. Then the rhythm is supraventricular. It is essential to analyze the QRS in all 12 leads to be sure that it is normal. If the QRS is wide, that is more than 0.12 second, and is bizarre, then the rhythm is either supraventricular with aberrant conduction, or it is of ventricular origin. It may be possible to differentiate the two by careful inspection of the QRS morphology. So that is the step 3. Now the step 4 is search for other clues. Often the diagnosis of a rhythm disturbance can be made by clues provided by breaks in the rhythm or other irregularities in an otherwise regular rhythm. As an example, an increase in the degree of AV block, as occurs with the carotid sinus massage, may unmask the flutter wave of atrial flutter. Capture beats and fusion beats may be the clues which help establish AV dissociation and a diagnosis of ventricular tachycardia. The regularity of the QRS complex should be established by asking the following questions. Do the QRS complex occur with regular intervals, or are they irregular? If the complexes are irregular, is there a pattern to the irregularity? Is the rhythm regularly irregular, that is, there is a repeating pattern of irregularity, or is the rhythm irregularly irregular without any pattern of irregularity? Only 3 supraventricular rhythms are regularly irregular, that is sinus arrhythmia, in which there is only one P wave morphology and a stable PR interval. Then multiple atrial rhythm, that is wandering atrial pacemaker when the heart rate is less than 100, or multifocal atrial tachycardia with rate more than 100, in which there are 3 or more different P wave morphologies and a PR interval, or atrial fibrillation, in which there is no organized electrical activity. So that is the step 4. Now the step 5 is interpret the rhythm in the clinical setting. Often the clinical history, including drugs being taken, can be helpful in establishing the diagnosis. As an example, a regular white complex rhythm in an elderly patient first occurring post myocardial infarction is most likely ventricular tachycardia. Similarly, a narrow complex tachycardia of sudden onset in a young person is likely to be AV nodal or AV reentrant tachycardia. However, the clinical presentation and associated hemodynamic findings do not necessarily correlate with the etiology of an abnormal rhythm. The presence of hemodynamic stability during a tachycardia, for example, does not imply a supraventricular etiology, nor does instability mean that the diagnosis is ventricular tachycardia. Hemodynamic changes are related to the rate of arrhythmia and the presence and extent of underlying heart disease. The basic principles of ECG analysis are following in the further video sessions, and it will include cases and MCQs. So please visit the site or the channel youtube.com/ACEPGMAT. If you have got Facebook account, make friends with the facebook.com/ACEPGMAT. After inviting as friend, click like. So that is Dr. N.S. Mani. Hope to visit you in the next video. Thank you.